right, good afternoon, everybody. We'll start the Multi-Modality conference today. Chest pain in the emergency room, what imaging modality? And you all have a lot of experience. We do a lot of that here. So a lot of these things will be familiar with you. But it's kind of good to go over a review, and because we don't know where you're going to end up practicing after you leave us. And as you know very well, it's the most common symptom people go to the ED for. And in many ways, they actually resemble a patient that you may see in your office. I mean, you may see in your office somebody that has been having chest pain for the past week. So it's really chest pain is chest pain. The difference is that when they come to the ED, there is a certain level of red flash acuity that comes with it. And people get a little bit more concerned. Why? Because although very high rate of non-ischemic etiologies are causing the chest pain that people present with in the emergency room, there is the potential for a catastrophe if one misdiagnosed the chest pain as being non-cardiac and the patient goes home and dies in a week. So that has created the aura of chest pain in the ED of being kind of more acute, red flag. But that same patient could have chosen to see you in the office. And you will still have to work with it, deal with it, work it up, but somehow that big aura drops down when the patient shows up in the office. And it's because of this issue of the emergency room. First of all, it's being seen by emergency room doctors. They have to make decisions. There's a lot of concern of the liability if you meet that diagnosis, as well as the patient situation. So all of that makes this entity kind of a lot more exciting, a lot more, we have to make sure that we get it well. We cannot miss anybody. So this here is a common algorithm that frequently is used all over the country, including probably here too, right? Somebody comes in with chest pain, you get an EKG immediately, and they draw a set of enzymes. You get a history, how the pain sounds like. Does it sound cardiac, non-cardiac, and so on. If the pain sounds really like angina, patient may have already some previous coronary disease history, bypass, maybe an MI a year ago, whatever, and the symptoms are very significant, you tend to admit them very quickly and treat accordingly. If it's a STEMI, as you know, go straight to the cath lab. But then there's a whole big group of patients that it's not clear. And their EKGs are either normal or non-diagnostic. And those patients usually, in the algorithm used by most places in the country, they're put in some sort of observation area. We have a chest pain unit at Methodist. Other hospitals may just simply have a little place where they have in the ED, a little place where they put them. But they tend to be placed in some sort of observation, and more testing is done. Usually you get another set of enzymes, and if now you have two sets of enzymes that are normal, frequently then you go to the next level, which is usually some kind of stress testing. But more recently, the whole era and the whole use of CTs, CTAs, is really making a very strong move. And Dr. Nabi will cover that. And there are trials now, randomized trials. So this is now becoming kind of like the new kid in the block to manage chest pains in the ED. So if you have this 55-year-old person that comes in with chest pain, it's not classic of angina, EKG is not diagnostic or normal, enzymes are normal, what would you do next? A, B, C, D. Turns out that if you look at the guidelines, they're all appropriate, actually. You will find that every single one of these tests is appropriate. Now, here at Houston Methodist, we tend to do a lot more of the nuclear stress and the CTs combined. So today, we're going to make a switch from previous years. I'm going to have Faisal come in first and discuss that, because that is what we tend to do most here at Methodist. And then at the end, if he's kind enough to give me a few minutes at the end, I'll come back and talk about regular stress EKGs and echoes. Again, for important information, and also because when you leave out, you may have to also use them depending on where you practice. So at this point, let's go ahead and switch. You ready to roll? So I can end the show, switch to yours, and make it very easy. I like that. Okay, and you just use this. for pointing and for moving. And you need this.
Thank you, Dr. Quinones. Good morning or good afternoon, everyone. So I'll just get into it. Some of this is, unfortunately, maybe a little bit of overlap with Dr. Quinones, but I think what Dr. Q, I'll kind of give you all the facts with all the research studies, and Dr. Q will definitely then, as you saw, kind of very nicely bringing it all together and kind of summarize what we can do with imaging in the ED area. Wow. Okay. So just to go over a little bit, like Dr. Q said, this is an extremely common problem. A lot of money is spent on this annually. But the most interesting thing is, despite the fact that we see tons of it, the actual amount of ACS is actually minimal. It's almost, in some studies, less than 20% of patients who come in actually have a problem. So vast majority of these patients really have, you can say, atypical chest pain or non-cardiac chest pain. And really, so our goal in the emergency room really sometimes is not to make a diagnosis of CAD, but it's really for risk stratification, to find out who is low risk and separate them from those people who are high risk. Because the high risk people should get admitted, and low risk patients can definitely go home and be seen by their physicians and get triaged further there. But despite, and really the goal of any imaging technique or anything we want to do is that we want to be able to identify a group of population before we send them home that has a standard in the ED literature is less than 1% risk of ACS. So that's kind of our goal. It has to have less than 1% risk. But believe it or not, despite that, still today the literature seems to be ripe with a lot of data. Between 2 and 5% of patients still get inadvertently discharged who have ACS. And unfortunately, this is the #1 cause of litigation against ED docs, internists, and cardiologists. So that's kind of the story. As Dr. Q said, these are the guidelines for recommendations. Most of these patients get admitted into some sort of observation unit for a 12-hour period of monitoring where they get serial EKGs, get serial enzymes. And then as he had said in the guidelines, and here I've underlined everything for you to see, all the tests that he mentioned are up there and are appropriate tests to obtain. And then guidelines also say, and I highlighted that in green, that if you do think that the patient, you can get these tests in the in the acute setting, or if you think they are truly low risk, at least upon discharge within 72 hours. So they do give some leeway, and I see this being practiced a lot in the community hospitals, where you'll frequently see patients seen, they'll discharge them, and they'll do all their testing in their offices. And this is just another flow sheet, another way that Dr. Q also showed of how we kind of manage patients. Acute, patients who have definite ST elevations or definite EKG changes or troponin elevations are admitted to the hospital for further management and therapy, whereas those who have these normal troponins and nondescript EKGs have further observation and testing to help you decide whether they have provocable ischemia and whether they can be admitted to the hospital or they go home. So exercise treadmill testing, Dr. Q will also go over this. A lot of literature is, obviously this has been around for a very long time. It's supported in the guidelines. Over 3,000 studies showing that this test has a high negative predictive value for ruling out acute coronary syndromes. So it works. And you know how cheap it is and how easy it is to do. But some of its limitations are that you have to have a patient who doesn't really have hip or joint problems. They have to be able to exercise. They got to get to their 85% of age to predicted maximum heart rate. And then, as the literature shows, that it may be very good in ruling out in the acute setting, acute coronary syndrome. But what happens when they come back to your office, in 2 weeks and say, "Doc, I'm still having chest pain"? How confident are you that they don't have CAD? So this is a study, and this was a very large meta-analysis, 147 studies, over 24,000 patients. that compared exercise treadmill testing to invasive coronary angiography, and you can see that the sensitivity of the test is quite low for a significant lesion by invasive coronary angiography. So this is where, we have difficulty with it in the acute setting. So what had that led to? That's led to a lot of functional testing where you do some imaging, and again, SPECT, echo, CMR, these are all great tests, all supported by the guidelines, and recommendations are, to use your local expertise and technologies. Now, they have all been shown, again, in the acute setting to have a very high negative predictive value for ruling out acute coronary syndromes, and I'll show you a lot of slides, a lot of that's done here at our institutions. And they've been shown to have actually a high accuracy for detecting CAD compared to exercise treadmill testing. So meaning their sensitivity specificities are much better than ETT, and generally on the order of all the tests are about 85%. That's kind of what I remember. You also, with some of these tests, get information about ejection fraction. You can localize where the ischemia is, and you can tell how much ischemia that the heart has. And some studies, like echo and CMR, can actually detect non-ischemic causes. So we're going to talk a little bit about SPECT, and actually there's two ways of doing SPECT. There's SPECT that you can do where the patient acutely presents what we call resting perfusion, where you assess resting perfusion. So this would be in the acute setting, where you have a patient who is admitted to your emergency room, who's having active chest pain right then and there, and you want to know is that ischemia or not. Because if you remember the ischemic triad, that if they have active ischemia, one of the most sensitive things, the very earliest on the ischemic cascade, is perfusion abnormality. So right then and there, you inject them with technesium, you image these patients, and you're looking for a perfusion abnormality. Now, it's helpful if they don't have known CAD. Obviously, if they have known CAD, then it becomes a little bit problematic, especially if they have known scar there. So this would be patients without known CAD. And this was a big study called the ERASE trial, very well known in the nuclear literature. 2,500 patients, 7 centers randomized to a rest myocardial perfusion study versus standard of care. Standard of care is what we've shown you, what we do every day. And what they showed was that there was no difference in outcomes. So really, if you went along this rest MPI strategy, there was no difference in outcome. But what there was a difference was when you looked at ED admissions, there was a marked decreased rate of admission using rest myocardial perfusion imaging in patients compared to those who had usual care. And this was really most pronounced in those patients who did not have acute coronary syndromes, whereas it correctly identified all the patients with acute coronary syndromes, and all those patients got admitted to the hospital. So in those patients who didn't get admitted, who did not have acute coronary syndromes, rest myocardial infarction led to much more confidence in the physician in sending that patient home, and with no change in outcomes compared to standard of care. So this is one, test that you have at your disposal, but the caveat here is they have to be having active symptoms or a very, very close period of time to when their symptom abated. And generally, I would say, 10, 15 minutes. After that, I'm not sure. You start losing sensitivity the more you wait if there's asymptomatic. So this was so nuclear, obviously the nuclear literature has a lot of data out there. This is data from our own lab. We looked at a prospective observational trial, 1,500 patients, acute chest pain. They all got gated SPECT. We followed them up at 6 months to see how they were doing. These were patients who were your classic ED patients, low to intermediate risk patients. Age was kind of middle-aged. The cardiac risk factors were there. Mean TIMI risk score was low. They all got gated SPECT imaging. You can see the percent abnormal here in this study was 8.6%. And this is not unique to our own population. If you look at emergency departments around the country that have published in this area, it's very common to have less than 10% abnormalcy rate. So, and just sitting in our nuclear lab, you know that a lot of these studies are normal, and that's normal for this population. And just to cut to the chase, this is what we showed. Basically, if you have a normal perfusion study over the course of 6 months, you are expected to do very, very, very well. Whereas here, those patients who have an abnormal SPECT, yes, there was some bias here. Those patients, if you have an abnormal SPECT, there's a, they end up going to the cath lab and having procedures. And so, here, our events were death, MI, ACS. These events were mostly driven by ACS or, the placement of a stent. So, but highlighting here, when you have a normal myocardial perfusion study, this study has a very high negative predictive value for acute coronary syndromes, and you can reliably, in vast majority of patients, be confident that they will do well when you send them home. And this is just our same data now, further, risk stratifying these patients. Obviously, the more perfusion defects, as your perfusion defect scores increases, as your degree of ischemia increases, you would expect risk to increase. Just for the sake of time, I'll skip over a few slides because I tend to have more slides than I need. This was just showing you that the SPECT data was additive beyond the clinical risk factors and beyond the TIMI risk score. So, imaging helped you risk stratify patients or help determine events beyond all your regular clinical risk factors that you have. And this is just then data looking at now in the same paper we published, we went back and looked at all the SPECT data in the emergency department setting. And you can see here, these were all major randomized trials published in the literature. Again, in every study, an extremely high negative predictive value for SPECT. So this went on then, and just most recently, this paper was also published in the literature, and saying, literally very much the same thing. So let's move on to CT. So CT, we know, is a fantastic anatomical test. It has a very high spatial resolution. We can generate beautiful, pristine images of your coronaries. And it's extremely helpful when your coronaries are normal, when there's not significant calcium there. We can really, really get a good feel of what is going on. But remember, it is an anatomy, and you really don't have much functional information. Now, if you look at the ability to diagnose CAD with compared to invasive angiography, this is now multiple studies shown on your screen. The data is consistent that the test has a very high negative predictive value. So meaning if we tell you that this patient does not have stenosis, you can be very confident that should your patient go to the cath lab, they will not find anything. And and this is probably the test that of all the non-invasive tests is the most sensitive test of all the tests we have to evaluate for coronary disease. But where it really falls apart, of course, is in positive predictive value, and there's many reasons for this. It can be, we fail in the setting of calcium, which causes blooming artifact and obscures your ability to look inside the lumen. Spatial resolution is not as high as the cath labs. You get some partial voluming, things like that. Of course, patients can have motion and those kind of things. But in general, I'll be showing you a series of studies where CT has been used in the ED. But in general, this is how they've all kind of used it. Patients will come in, they'll get an EKG. If it's non-diagnostic and the initial biomarkers are also normal, they'll get a coronary CTA. And as long as there's not a significant stenosis, as long as you identify, no plaque or non-obstructive plaque, most of these patients will go home immediately. So there have been now almost 2,000 patients, randomized patients, who have been studied compared to standard of care. Standard of care mostly has included SPECT, but it has also included exercise treadmill testing, and in some studies, whatever was available at the institution, so stress echo as well. And you can see that progressively as the years went along, the patient enrollment increased, so the highest ones were 1,000 patients. And in general, they were all generally the same type of patients. These were low to intermediate risk TIMI patients or, who had chest pain, but they had a normal or non-diagnostic EKG and normal initial biomarkers. So these were not patients who had bypass grafts. These were not patients who had stents. These were not patients, who had low EFs. These were patients who presented with chest pain and told you, their initial biomarkers and EKGs were normal. And what the data was very consistent in showing, and this is now meta-analysis of all these 4 large trials that I mentioned, was this is just now the patient cohort. You can see, again, middle-aged, TIMI risk score, just like our paper, between 1 and 2. Risk of ACS extremely low, 4%. So now, you get the feeling that ED populations around the country are very much similar. And what they found was that if you did a strategy of CT versus standard of care, there was no difference in death or myocardial infarction in follow-up in all of these randomized trials, and then, looking at them as a pooled group. So this was very reassuring that CTA is safe, that if you do choose to employ this strategy, you're not going to miss ACS. But what they showed and then if you go ahead and then look at other studies that have been published, the story becomes very, very powerful, that again, if you have a normal study, the negative predictive value for this test is exceptionally high, and you can be confident that nothing bad is going to happen to your patient. But what CTA did show was so why is there excitement about it? Well, the excitement about it was when you looked at time to diagnosis compared to the study that compared to usually nuclear imaging, you were able to, in all of these studies, cut your time to diagnosis almost by 50%. So these patients would come to the lab, with a little bit of beta blockers and nitroglycerin, bam, you would have imaging done in 15 seconds, and as long as you had a doctor to read it, these patients were going home. And that decrease in time to diagnosis obviously led to less ED costs, and then as a result of that led to decreased hospital duration. Led to less hospital duration, and as a result of that, if you looked at costs, there was market cost savings. So this is where the excitement of CT was, that you had a test that could make a very rapid diagnosis and actually save some money, at least in the inpatient setting. Now, there was one study that looked at overall hospital costs in the acute setting and then in follow-up. That was ROMI-CAT2, and that they didn't really show any difference. But those things all come down to how a doctor deals with the information then when in follow-up. But at least in the acute setting, it seemed to be a good way to quickly clear out the ER. And this is just a graph from one of those papers, kind of showing you that the event, if you look at the far right-hand side of the screen, that's when everybody gets discharged. And this is just a time course of how patients are being discharged. With CTA, you were getting discharged within 8 hours. A large proportion of your patients, more than 50%, were being sent home. Whereas to get 50% with of your patients going home with the other standard of care, it was taking almost a full day. So just a quick graph. Now, one caveat to all of this is obviously, how are you doing your stress studies? We're using stress-only protocols. There's so many things. But these were 4 trials. They all were consistent. They had the protocol they were using was rest stress imaging, and this is what they were demonstrating. Now, the other interesting thing that it was shown was that, no one was dying. We were sending home patients faster. But then they were like, because we don't have great positive, our specificity is a little bit less. Is that leading to more angiograms? So actually, it turns out that if you pool all these studies together, it does seem to suggest that there is an increase in invasive coronary angiography and percutaneous coronary interventions in patients who have a CTA strategy. Now, this is debated, and some studies show it, some studies don't show it. This is just a study of a pooled analysis of all of them. So take it for what you may. And, so that means most studies, seem to suggest there was an increase. And they said that on the order of about 20 patients per 1,000 are extra will be going to the cath lab. And so therefore, but so, and this is also debated. Does this lead to more costs? Does it not lead to more costs? Some people have proposed that, well, if you're able to clear out the ER so fast in a lot of patients, these these few patients that you do send to the cath lab, the cost should average out. Right? It shouldn't necessarily add too much cost. But that is one of the limitations in all these studies is that it's hard, they don't have very comprehensive long-term follow-up and, watching patients and how physicians deal with that and, following, what they do with the results of these studies. It's kind of one of the areas that definitely can be looked at, the long-term impact of these studies. So then, there was this other trial that most recently popped up. This was 400 patients published in 2015. They also decided to randomize CT versus SPECT, and really found no change and really no difference. We also did our own. We did the largest single centers trial, almost 600 patients. We randomized to CT and to SPECT, and I think we did some unique things. With our CT strategy, we actually got calcium score before CTA because we were very interested in calcium scoring at that time and at this time as well. And then for SPECT, we decided, hey, you know what? Instead of doing rest stress, what everybody else is doing, we've been a leader in stress-only imaging. We're going to start with stress first. And those patients who have normal stress perfusion imaging, we're not going to do the rest images. They go home like they would do every day here in our lab. And so we followed these patients up at 6 months. Our overall event rate, again, was very consistent for our own site and also compared to ED literature out there, very low, less than 4%. These were our demographics. Really, I wish to highlight nothing particular. They were your classic low-risk patients, low to intermediate risk patients. And this is what we found. If you look at if it comes to total MACE, all the studies have shown equivalence. We also showed the same. If you had a normal CTA or a normal SPECT, you did very well, showing the high negative predictive value. Whereas if your studies were abnormal, it probably led to further testing, and there was a difference in mostly driven by revascularization and not death MI. But what was interesting, what we found? Well, in our study, if you looked at all the patients who went to SPECT and you looked at all the patients who went to CTA, CTA was faster. So we definitely cleared patients. They went home faster duration than those who had SPECT imaging. However, the caveat, what was interesting, this was everybody. But what was interesting was that in those patients who specifically had stress-only SPECT, so they had a stress, it was normal, they got sent home, there was no difference between stress-only SPECT and those patients who had a completely normal CTA. So this was one of the first studies to show that, when it comes to trying to figure out which test is faster, you really have to optimize both tests. So if you optimize SPECT with stress-only SPECT, you can perform just as fast as CTA. And this is really, so we've really taken this as a charge to show our administration that, look, both tests are very good. Stress SPECT is, the standard here in our hospital now. We really, really look for an excuse. I mean, we really have to have a very strong excuse if we're ever going to do rest first. We're going to proceed with stress first because we can feel we can get these patients out just as fast as with a CTA strategy. And this is then just time curves that you had seen showing that really, further things. When we looked at radiation dose, what was interesting was if you looked at the radiation dose of stress-only SPECT, it was 5 millisieverts. At this time, we did not have our dual source. We were using our 64 slice, and the lowest radiation you can do with that is perspective gating. And you can see the radiation dose with prospectively gated scan, on average, was about 5 millisieverts, which is exactly what we had with stress-only SPECT. So even radiation doses, can be optimized and can be significantly reduced with a nuclear strategy. And then when it came down to resource utilization, we did see a trend in some increase in outpatient testing, especially cath and revascularization, similar to other data. And so, to summarize, for stress-only imaging, it's similar to CTA in time to diagnosis, length of stay, cost, with the same prognostic accuracy and with the same levels of radiation with a normal CTA. Future directions, I think, hopefully be very exciting if we can get FFR over here. You can imagine having a CTA and then having functional information, so we'll increase our specificity. And I think this would be an interesting. Look for these studies in the emergency department as well. Now, calcium scoring is, I'll keep it short because I have to give Dr. Q some time. So there's been a lot of thought. In the asymptomatic patients, we know calcium scores have excellent prognosis. They have very, very low risk of having coronary atherosclerosis, very, very low risk of having an abnormal SPECT. So people said, hey, how about in the acute setting? And believe it or not, we've done a lot of research in this area, and we can go over it at some other time. But basically, we showed in a very large cohort of patients that, if you had a calcium score of 0, you had almost less than 1% chance of having an abnormal SPECT. And not only did you have an abnormal chance of having a less than 1% chance, you had only 2 out of 625 patients who had a cardiac event. And this is data from our own lab. And who were those 2? It turns out those 2 patients were both patients with acute, with troponin elevation, so they were diagnosed as acute MI, but they had normal stress images during the index hospitalization. So they had some troponin elevation, their specs were normal. I'm not sure what exactly it means. Maybe it wasn't even related to myocardial injury. So this was one trial, and then, I guess this is the real paper, slide I can spend a little bit of time on. If you now look at the data out there using calcium scoring, and this is now almost 2,300 patients, the sensitivity is 96%. The negative predictive value is just like CTA. It's just like SPECT, and just like echo, exercise treadmill testing. Very, very powerful. If your calcium score is 0, at least in multiple trials by multiple different people over multiple years in the same low-risk population, they seem to do well. Now, we're not saying that these patients don't need evaluation. We're saying they can be cleared from the emergency room. They can go and follow up with the outpatient doctor for further evaluation. Now, everyone has a story, that, your calcium score was 0, I cathed him, he had a big soft plaque in the LAD or the left main. Yeah, that is true. There's, but I would also say everybody has those same stories for SPECT. They have the same stories for echo. They have those same stories for any of the non-invasive testing. So the goal, no test is going to be 100%, but, for vast majority of patients, is the test effective? After that, we have to be physicians as well. If you have very, very typical symptoms, how many times have you all received normal studies and you've pushed on with further testing because it just didn't feel right in your stomach? So, in the end of the day, we also have to be physicians. So, Dr. Q, I'll leave it here.
Thank you, Faisal. That was really good, and that recent data is spectacular. Very good. So what I'll do here now, if I can remember how to do this, is switch back to the other side over here. Okay, so we talk about that, and you can see now why I wanted Dr. Nabi to go before me, because I think the data he presented really is the most state-of-the-art data we have, and it's very semblance of what we do here at Methodist. So first I'll show you this. Even though the treadmill doesn't have a very good sensitivity, as you can see here in this pooled data, and even specificity, both are not that great. That's true, okay? In essence, a treadmill ECG is a mediocre test. That's the best way to define it. However, Um, oh, also, given the prevalence disease around 20%, the positive predictive value is quite low. So I would say in the office, it's not, it's, you have to think about when to use it appropriately because a negative test doesn't mean the patient doesn't have disease, okay? And a positive test could be a false positive. Not everybody can exercise. However, this is the important part. In the emergency department environment, because of all the demographics that FAISAL so nicely showed, if a patient has a normal stress echo, they have as good a predictive value for benign outcome as everything else that was shown. And that's why in community hospitals, quite often this is used. They even have a treadmill. Some hospitals have a treadmill in the ED. And they put patients who are otherwise healthy and can exercise right there because if they clear the treadmill and they do great, they go home. And that has been a practice that has been around for 2, 3 decades. This is not anything new. We don't see it here because we are in a more tertiary care center. If you go to small community hospitals, this is not an uncommon practice, okay? Because of the fact that if you apply the Duke Treadmill score for outcomes, which hopefully all of you do know, this is what you see. Very good survival for negative tests. So in the ED, if all you want to try to decide this patient will do okay for the next 3 months, go ahead and get an appointment with your doctor and get further workup in the clinic, it can do the job. And that's the reason why a lot of small hospitals do it. Yeah, yeah, because basically it's a treadmill test. Obviously, you don't have a pharmacologic EKG test. So basically, it's just exercise times, the usual business. So this can be used in any system. And I did not know this until I started to meet more people and talk about with community physicians. And actually, in a lot of little towns around, people still use this because of that. I mean, there's data to support, and that's why it's appropriate. That's why still the guidelines say it is an appropriate test. Yes, Steve? Well, yeah, we'll get to that. Absolutely, yeah. Now, obviously, you have a lot of negatives, you have a few positive, and then you still have these to deal with. In an ED environment, then that will be a group that you would have to move to some sort of further testing. Nuclear and stress echo, both are appropriate, and Faisal covered this very well. In fact, this is a piece of his slide that he showed you from his work, that if you have a negative stress nuclear, you have excellence. So, I mean, again, similar, and the same thing has been shown to stress echo. So, if you're going to go the way of echo, then remember that in this algorithm that we have shown before, where if the patient is non-diagnostic, you put them in some sort of observation area once the enzymes are okay, and you do some stress testing, and if you go the way of echo, already having abnormal resting wall motion would be a red flag. So if you go to the stress echo and the resting portion already is abnormal, that's a red flag. That patient has trouble. So if you have an abnormal resting wall motion or abnormal stress echo with distress, then that's a patient that's going to be obviously admitted for further testing. If it's normal, they go home. Question again here is the time involved, how much time you waste. Very important. If you're going to use this algorithm for patients coming through an ED setting, really, and this is for fellows here because we get a few patients occasionally sent for stress echo, the best test is an exercise stress echo. So if patients really are otherwise healthy, they should exercise. The butamine is a second-tier test in terms of accuracy. But if they cannot, that's a different story. But I'm a little disappointed. I see a lot of the butamine stress echoes being ordered, people that you look at them and you know they can get up and get in a treadmill and exercise. And then we end up with a mediocre test. Go ahead, Jeff. Yeah. No, we don't have that here, and I agree with you. I agree with you. And what happens here, a patient is sent for dobutamine, and then people don't want to change into exercise without the permission of the doctor, and then that further delays, so you end up doing the dobutamine, which really is a mediocre test. Dobutamine stress echo is a mediocre test. It doesn't have the same qualities overall of exercise. And if the patient has hypertension and LVH, it's even worse. So my plea to all of you, if you take a look at the patient and he looks like a healthy guy who can get up on a treadmill, try to see if you can change it to a treadmill, because it is a better test. So this guy comes in, and his resting echo shows that. So that's already somebody that you'll be concerned that needs something else. Just because already at rest, you're having inferior wall and apex, so you have LAD and RCA involved. You need to do something about it. That's the kind of patient that probably will already have a history, that they already had some trouble before and whatnot. Those are patients, those are not the 60% that FAISAL showed that you can clear very quickly and ship at home by whatever test you do. Also, the echo once in a while will pick up other causes of chest pain. Now, CT will too, right? So those are advantages of CT as well as stress. Nuclear is a little tougher. But when you do a CT or an echo, you could pick up these other things like pericardial effusions. Occasionally, you're lucky to pick that up with a regular echo. We all know CT would be a lot more accurate for that. FAISAL didn't touch on that, but there's a move towards the triple rule out because doctors don't want to be doctors anymore and take a good history. So they think that they can do a CT and exclude the PE, exclude the dissection, and, oh, by the way, exclude the ACS. I am a little skeptic about that being the best way to manage patients depending on everything. Go ahead, Steve. Yeah, so echo in chest pain has basically very little value. And we still do a bunch of them. I've been pleading with the administration to control that. You see it in our own lab, chest pain, 99% they're normal echoes. So resting echo, unless you are truly suspicious of pericarditis because of all the qualities or something else, or the patient comes in with a history that they already had an MI and whatever, and you want to know the LV function, that's fine. That's very appropriate. But on that 60% universe that FAISAL talk about, that come in with chest pain, no specific EKG, and eventually they clear out, resting echo is basically an expense that is worthless. And the only way we can control that is if we're given the authority to say no. Until now, we haven't. But I think at some point in time, now that, if you remember Dr. Phillips' grand round last week, cost is becoming an important issue. Maybe eventually we will be given the authority to say no, because it is a worthless test. Go ahead. Yes, that could be just as used, perhaps just as used. And in fact, 25 years ago, when people were in the bandwagon of trying to use echo for everything, there were papers written about that. That if you catch the patient at the time of chest pain, yeah, and you see one motion, you're golden. How often do we do that? So reality, practical value, it's really not for discussion. Okay. Now, this is an important question. This is the new kid in the block. What about the super sensitive troponins, right? And that's coming quickly as another wave. So as you know, you have now these very sensitive troponins. And this was a study that came out in the New England Journal in August of 2009. And basically, you can see here, at that time they were using different kinds of companies providing the high sensitive troponin. All of them, you could see a very nice distinction between the values, okay, the 99th percentile for the troponin levels, all the values here in the people with the threshold that had non-cardiac cause were all here, okay, unknown that need more work, and then you have here unstable angina and cardiac causes, so that they could find a threshold for differentiation. So this just came out. This is from, this was in JACC just a month or so ago. So outcomes in patients with chest pain discharged after evaluation using a high-sensitive troponin assay, and is from Sweden, which has a very, as you know, has a very unique and interesting and perhaps one of the best healthcare systems in the country. So 66,000 patients. I mean, the Swedes don't fool around. As you know, they have a very unique system that truly allows them to collect massive amount of data. Coming with unspecified, the typical patient we're talking about. Unspecified chest pain, discharged from 16 Swedish hospitals between 2006 and 2013. High-sensitive assay was introduced, and they were evaluated with both conventional and high sensitivity assay, okay? And then they look for 30 days MACE and also for the risk, cardiovascular risk profile. Fewer directly discharged patients experience a MACE when evaluated with the high sensitivity troponins compared with conventional. 0.6. I mean, we were talking about doing good with 0.8 with calcium score. This is 0.6 versus 0.9 ratio. So I mean, it's pretty damn good to send somebody home and have them see their doctor. So the conclusion was that patient directly discharged from the ED with unspecified chest pain experienced fewer MACE and had a better risk profile when evaluated with the high sensitivity enzymes. I think this is going to start making a wave in the US too, because this may be the cheapest of all the options we have been discussing. So I think I would say stay tuned for that one, because I don't think we have yet adopted it as the way to go, but the wave is coming. And you heard again grand rounds last Thursday about the importance of reducing costs for all institutions in the healthcare system in the US. So I predict that we are going to see a lot more of this, and maybe the algorithm will be, you pass, go home. You're borderline or positive. If you're very positive, you're going to go obviously for admission or more. If you're in some borderline, they might go for CTA or who knows what. So I think that stay tuned, because we may begin to see a lot more of this potential approach show up as an option. And I think it could be potentially a very good option. So it's like we have 5 minutes left, which is great, because it's a good topic to have some questions and discussions. Steve, you're the only representative of the Canadian system. And that was not even high sensitive. That's just still the, yeah. 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 No, I think clearly we know why we are so hyper in the US. You know that there is an issue with the liability factors, and that being the number one. I don't know if I said it at the introduction, but until, I don't know if it's today it is, but until a few years ago, it was the number one cause of litigation in the US for emergency room practice. Number one. So that's, I think, tells you why everybody has become so hyper about trying to get that 8% that happens to do have disease well picked up. Questions, discussions, you guys, you can throw your own ideas if you want to. We see a lot of that here, so. Contrast perfusion echo. Dead horse. Next topic.
Well, that's why I said I was going to bring it up, but then I was like,
It was a great idea. It was a great idea. Actually, if one could potentially have that wonderful, wonderful agent that you could shoot it right there and see the perfusion defect, it would be phenomenal. It just didn't happen. Hasn't happened for many reasons. One is the ideal contrast agent has not been found, and B, all the techniques needed to make everything work is not there yet. So it's not a practical thing right now, after 30 years of people working in the field. Any other discussion points? And if not, thank you very much. We'll see you next week. Will you give me permission to copy your talk? It's fantastic.